Well, good afternoon, everybody, and welcome to day 2 of this GRAPPA workshop, which has been kindly sponsored by Novartis, APME, and in collaboration with the Saudi Society of Rheumatology. For those of you who were not here yesterday, in day 1, my name is Elena Martha Ortega. I'm a rheumatologist based in Leeds, and it is my pleasure, together with my colleague Philip Helliwell, to welcome to this workshop. And I'm handing over now to Professor Helliwell.
Thank you, Helena, and welcome back, everybody. So today is going to consist of workshops followed by a plenary session. You'll be streamed into either dermatology or rheumatology workshop according to your profession. So in the rheumatology workshop, there'll be 4 workshops, starting with Treat to Target, led by Laura Coates. The second workshop will be Axial Disease Assessment and Treatment by my co-chair, Elena Martha Ortega. The third workshop will be on Enthesitis Assessment and Treatment, led by Dennis McGonigal, who you heard yesterday. And the fourth workshop will be on Dactylitis, Pathophysiology Assessment and Treatment, run by myself. In the dermatology workshop, again, there'll be 4 workshops, starting with difficult to treat psoriasis, led by Kavi Shams and Miriam Whitman. The nail disease session will also be led by Kavi and Miriam. Thirdly, there'll be a session on what should dermatologists look for in terms of identifying psoriatic arthritis early. And I will be helping run that workshop. And finally, the differential diagnosis of palmoplantar problems. I will say that each workshop will have an international faculty who I've mentioned to you, but also local faculty supporting. And I hope that you are able to interact in each of these workshops and also have a chance to discuss specific problems with the faculty presenting those subjects. And at the end of the workshops, we'll all come together and have a plenary discussion on any subject you wish to ask us before finally closing the session. So I hope you enjoy the meeting, and we'll talk to you all again later.
Hello? Can you hear me? Hello? This is Dr. Fahd Al-Aqeli, consultant rheumatologist from Prince Sultan Military Medical City in Riyadh. Gives me pleasure to introduce our next speakers, Prof. Laura Coates, who was introduced earlier yesterday, who was with us. Prof. Laura is Associate Professor at NAFL Department of Orthopedics, Rheumatology and Musculoskeletal Science, University of Oxford, UK. And our speaker is also Dr. Khawla Al-Ghanem, who is a consultant rheumatologist and systemic lupus erythematosus specialist in King Fahd Military Medical Complex in Dhahran, Saudi Arabia. She is a board member at the Saudi Society of Rheumatology and a member in the American College of Rheumatology. Dr. Khawla is also a reviewer in the Saudi Medical Journal and has several published scientific research papers. Both of the speakers are going to speak about implementing Treat to Target. Welcome, the mic is yours, Dr. Khawla.
Thank you, Mr. Chairman, and good morning and good afternoon for everyone. Our topic for this session is Treat to Target in psoriatic arthritis. I'm going to speak about the first part, the theoretical part, and Prof. Laura will take you to the real scenario by the end of my talk, inshallah. Treat to target approach or strategy is not a new one. It has been used in different diseases like diabetes and hypertension, and other rheumatological diseases like rheumatoid arthritis. However, psoriatic arthritis is a different disease. It's a challenging one because it has multiple domains and heterogeneous clinical spectrum. That's why controlling all the domains together is challenging sometimes in some patients. Treat to target strategy idea has started since 2014. I will take you through this journey from 2014 until today, what's happening in this strategy with regards to psoriatic arthritis. Why this is important? Sorry. Why the treat to target strategy is important? Because we have to prevent unfortunate sequelae like deforming joint, erosive joint, and functional disability. The most important question that I would like to ask everyone here is hearing me, what is your target when you have a patient in front of you in your clinic with psoriatic arthritis? Do you have any target when you treat your patient? The second interesting question, what disease activity measure do you use in your daily clinic? Do you use any specific measure? Do you have this mixture? You don't have anyone. You can write in the chat, and I'm gonna take your answers by the end of my talk. As I mentioned earlier, treating the psoriatic arthritis as early as we can and keeping the patient at remission stage or minimal disease activity is really important to prevent unfortunate sequelae. And the most important one is deformed joint and functional disability. That's why it's really important to improve the outcomes for patients with psoriatic arthritis by using a stepwise approach. Starting from the first point, from the day one, we have to reduce and to think how to reduce the diagnostic delay in our patient, how to implement a treat to target approach, and how to maximize a long-term outcomes, and keeping our patient as much as we can for a long period of time at remission or minimal disease activity. The challenging question in my presentation is there is any evidence in the literature that a treat to target strategy or approach is better than standard care in psoriatic arthritis patients? To answer this question, I'm going to take you to TUCPA study, which was done in UK, and this is the first randomized controlled trial. They were testing the clinical and patient-reported outcomes with the treat-to-target approach in psoriatic arthritis patients. They did include 206 patients, and these patients were randomized to two groups. The first group was standard therapy group, and this patient has been followed per treating physician. There were no specific time to follow these patients. However, in the other arm, in tight control group, they were reviewed regularly every 4 weeks, and the medication escalated by using MDA criteria every 12 weeks if they didn't meet these criteria. And this study was continued until 48 weeks. The primary endpoint for this study was ACR 20 at 48 weeks. And the result was promising. The patient with a treat to target strategy did have higher ACR 20 response when they compared them with standard care of therapy. As you can see in this diagram, this is ACR 20. They checked as well ACR 50 and ACR 70, and you can see how these patients in the green, in a tight control group, they have higher ACR 50 and ACR 70, which is something good. It means that this tight control strategy is working in these patients. Something that I would like to mention, what about the serious adverse events in these groups? As expected sequelae, patients in tight control group, they will be in more medication, so the adverse event will be higher in this group. So it was 10% in tight control group and 6% in standard care group. However, there were no unexpected serious adverse events or deaths, which is something good. Another point that I would like to mention from this study, TUCPA study, as you can see here at week 48, the patient in tight control arm, they were in biological therapy more than the patient in standard care. It means the escalation of the medication is higher, which is something expected when you are seeing your patient regularly and you are using measure to check for the disease activity, then you escalate accordingly. That's why GRAPPA group taking this as first recommendation in their 2015 GRAPPA treatment recommendation to implement treat to target in patient with psoriatic arthritis as a first recommendation in their guideline. This is a beautiful slide. As you can see, our patients in psoriatic arthritis, they have multiple domains. So you have to escalate the medication accordingly. As we know, what is benefiting patients with dactylitis, it doesn't mean it will work in other domains. That's why we have to follow this nice recommendations. This is another beautiful study from non-rheumatic diseases published in 2017. They are taking the patient with AS and psoriatic arthritis, and they are using the same approach, treat to target. And they are end up with beautiful guidelines to us, which is really wonderful, I think, a study. The first one was the treatment target must be based on shared decision between patient and rheumatologist, and the treatment to target by measuring disease activity and adjusting the therapy accordingly to optimize the short-term and long-term outcomes. And with regards to the SPA and as well as psoriatic arthritis, they are multisystemic disease, so we have to control the MSK and extra-articular manifestation, and we have to share this with other subspecialties like dermatology, our colleague in gastro, and ophthalmologist. And by the end, the goal of a treatment for the patient with axial SPA or psoriatic arthritis are to optimize long-term health, related quality of life and social participation, and the preventing of structural damage and normalization or preservation of function. Then, what is the best outcome measure that we can use in our practice, in our clinic, to escalate the medication? The answer is really challenging, but I will take you through this study, which was published in 2017 from non-rheumatic diseases. What they did use the MDA and DAPSA score. Then they escalate the medication accordingly. What is MDA and DAPSA score? MDA, when you have your patient meeting 5 out of 7 criteria, and very low disease activity, or in another word, remission, when your patient meeting 7 out of 7 criteria. What are these criteria? The first one, tender joint count less than 1, swollen joint count less than 1, BACI score less than 1, patient pain VAS less than 15, patient global activity HAC less than 0.5, tender enthesial point. So this is, I think, very feasible measure, the MDA criteria, and very quick when we compare them with other measure. Let's take there was recommendation in 2017. They make like an update with regards to the treat to target, with regards to the SPA in general, that a major treatment target should be clinical remission or low disease activity of MSK and extra-articular manifestation. This is the last updated one, recommendation from EULAR with regards to the treatment of psoriatic arthritis. As you can see, you have to classify your patient first. Does my patient has polyarthritis, oligoarthritis, enthesitis, axial SPA? Then you have to move between these medication accordingly. And you use a step-up approach or graduated approach. As you know, we have too many measures with regards to the psoriatic arthritis. We have as well composite measure. So what are they and which one is better to use in our clinic? I'm going to talk about the theoretical part, but Prof. Laura will take you to the real scenario patient, and we will apply these measures in real patients. So the first one, MDA, just I'm going to mention briefly what is the benefit, what is the advantage of this MDA, and when we compare it with other, it's very quick and feasible one, and we don't have to have blood work, CRB. We don't have to have it. So this is very quick, very easy to apply. The patient can do part of the job and we can do the other part. However, the DAPSA score, it's a quick, feasible, but you know, it needs CRB. So might this delay us from calculating this score in our busy clinic. That's why maybe MDA is better than DAPSA score. And in another hand, if we think about what about articular and non-articular manifestation, which one is better? MDA, in fact, is better than DAPSA score because MDA checking enthesitis, function, and the skin, which is not checked in DAPSA score. And MDA is not requiring blood work like CRP, like DAPSA score. So it is more feasible when we compare it with DAPSA. However, both of them, they are good and a great measure. Another composite measure, I'm going to take you very quickly for BASDA's score. It's validated composite index, joint, dactylitis, enthesitis, and the quality of life. However, this measure a bit complicated, need online calculation. It has 8-item score, and we have to calculate SF36. So it's a bit complicated when we compare it with other. And this is just to lump everything together, summarize all the what I mentioned before, MDA, DAPSA, and BASDA's score. And these score actually they are using, this is what they are used commonly in research and the clinical trial in psoriatic arthritis. This is another composite measure, composite psoriatic disease activity index. However, this is a bit slower and not developed from evidence-based and require, you know, joint, skin, enthesitis exam as well. If you want to check the impact of the disease, you have to go for psoriatic arthritis impact of disease. This is checking everything regarding the effect of the disease in the daily life of the patient, including the sleep, anxiety, depression, functional capacity. This is has been used as well in clinical trials. If you want to check the response for the treatment as well, you can use psoriatic arthritis response criteria. This outcome measure has 4 domains: swollen joint, tender joint, patient global, physician global, but is not as used as other measures in clinical trial. So that's why we have too many outcome measures, but which one is better? What I believe, maybe MDA and DAPSA, they are better. However, MDA is better than DAPSA because it's multidimensional score. What about enthesitis? I know that my colleague in the next sessions, they're going to present about the enthesitis, but just I'm going to mention the name. We have multiple score in measuring the activity for the enthesitis, MESIS, SPARC, IMPACT, LEADS, and the most common 2, LEADS enthesitis index and SPARC. What is the difference between them? LEADS enthesitis index checking 6 side, while the SPARC, they are checking 16 side. Moving to the dactylitis, I know that we have as well session, but I'm going to mention just a name about the score because maybe Prof. Laura will apply this in a real scenario. We have simple count and severity grading, LEADS dactylitis index. What about the skin? Skin assessment, we have 2 score, BASI score and percentage body surface area, keeping in mind that patient full handprint equal 1% body surface area. What about nail disease? We have NAPSI and modified NAPSI score, nail VAS, And usually this is checked by our colleague from dermatology. At the end, I would like to share with you this slide because it has like very, I think, wealthy information. GRAPPA, they did make application for these outcome measures that we can upload these outcome measures in our mobile or laptop, and we can use them in our daily busy clinic, which can make our life easy. By the end of my lecture, I would like just to say that you have to plan your goal, because a goal without a plan is just a wish. Now I'm gonna give the mic to Prof. So I'm gonna now share the mic with my colleague, Prof. Laura.
Lovely. Thank you very much. That's a lovely quote to finish on. I love having a goal that's more than just a wish, so that sounds great. I'm just going to talk briefly about a couple of cases. You heard my disclosures yesterday. So when we're implementing MDA, we do this with the patient in the waiting room initially, and depending on our clinic and setup, some of our patients are in studies and they do the questionnaires on a tablet computer. Some of them do it on paper. So the patient completes a hack, a pain VAS and a global VAS in the waiting room before they come in. And then within our clinic assessment, we would do a 68-66 joint count, an enthesitis count and a skin assessment. So Dr. Howler's done a lovely job of introducing all of the measures, which makes my life a lot easier. So we routinely check the Leeds enthesitis index, but I would also check any other tender sites that a patient mentions. So this is a good screening tool as a minimum, but if somebody has significant enthesitis at the shoulder or the hip or elsewhere in the knee, then I would also examine that as well. In terms of assessment of psoriasis, you heard the mention of body surface area just a minute ago. We do PASI scoring for a lot of our trials, but it's difficult, it's complex and it's slow. And I'm a great fan of the body surface area method. So one handprint, the patient's handprint, ideally, particularly if they're a bit bigger or smaller than you, is equivalent to around 1% of the body surface area. And for minimal disease activity, we're looking for less than 3. So this is the app that you saw. This is the screen that you get at the end. So on the left-hand side, you can see the MDA results. So you can see each of the items in MDA, which are met, which are not met, and that's color-coded to give you the idea. So that if they're not in MDA, even if they are in MDA, you know if there are particular items that remain high and need treatment. And that the app also includes the PSAID, which you see here on the right, which measures impact of disease, and this gives you a total score, which you see at the bottom, but also tells you which of the aspects are problematic for the individual patient. So I'm going to talk about a quick case. So this is a 35-year-old dentist who's had psoriasis and psoriatic arthritis, as well as quite severe nail psoriasis. And that's difficult for him in his job because he finds it difficult to do fiddly dental procedures with damaged nails. He presented with a small joint polyarthritis, was treated initially with methotrexate and then with leflunomide as well. He's still got quite significant psoriasis with a body surface area of 8%. He's got worsening enthesitis. And you can see here on the right, he has 4 tender joints and 3 swollen joints in the hands and in the lower limbs. So his leflunomide was stopped. He was treated with etanercept, and he also stopped the methotrexate shortly after that as well because he wasn't tolerating it well. Coming back on treatment on the etanercept, his joints have got a lot better, but he still continues to have bilateral Achilles pain, and you can see a body surface area of around 6%, as well as some inflammation in one knee. So the question is he achieving minimal disease activity? So his joints are well controlled, but you can see here that his patient-reported outcomes remain high. His HAC remains high at 1.25, and he's got a high body surface area of psoriasis. So he was switched from etanercept to secukinumab, particularly for the nails and the skin disease. And you can see here, this settled quite nicely. So he still had one tender joint, but the psoriasis improved a lot, as did the enthesitis. So now is he in MDA? So his joints now are well controlled. His global is also well controlled, as is his skin and his enthesitis. His pain score is just above the threshold. It's 18, and ideally we'd like it to be 15. And his HAC is just above the threshold as well. So he meets MDA because he's meeting 5 out of the 7 cut points. He's not in very low disease activity, though. We haven't controlled all 7 of those items. But obviously, it's relatively early on secukinumab. He's had a very good response. So in this case, I would continue the medication a little bit longer and hope that the pain and the function would improve, possibly with a bit of physiotherapy or additional treatment if required. So we know that treat to target has been shown to improve MSK and psoriasis outcomes. You saw that from the lovely talk from Dr. Howler. We know that sustaining a target is important for long-term outcomes, and the MDA targets are more stringent than the DAPSA targets, and also importantly cover skin and enthesitis as well. When we are implementing treat to target, it's really important to think about joints, entheses and skin. If you're doing that, use the simplest measures for each to try and make that easy. And you can measure minimal disease activity or a similar target. You can use DAPSA and then separately measure skin and enthesitis. But as I mentioned yesterday, it's still important to treat the patient as an individual. So there may be some patients in MDA where you would still increase therapy if there's one particular thing that they're struggling with. There may be some patients who are not in MDA, but they don't want to increase their therapy, or they have high patient-reported scores from osteoarthritis or fibromyalgia, where you may want to institute a new treatment, but it may not be a disease-modifying drug. It might be physiotherapy or pain referrals. And that's the end of the workshop. Thank you very much.
It's open now for discussion. I'd like to invite any questions, either by writing it down, or you can raise your hands and share with us your question. While they are, preparing their question, I may, take the opportunity of raising my own question. Switching from, a biologic to another, this is one approach in order to achieve treat to target. Sometimes we get exhausted, or the patient get exhausted of changing several biologics without, reaching his optimum remission. My point is about combination of biologics with the risk of infection of all the other things. Which combination you think is probably safer, or you will adopt in case if you face a very refractory case?
So I think we need more evidence. I think that would be really helpful. In the UK, there's no way, particularly where I live in the UK, because it varies by region, there's no way I could get 2 drugs funded. So I can use a biologic with a conventional DMARD as a combination. We often try and optimize methotrexate or leflunomide, or another drug to try and boost effectiveness, as well as topical therapy for the skin or phototherapy for the skin. But there is not a chance that I could get 2 biologics funded. It just wouldn't happen where I am in the UK. They are very strict with our drugs.
All right, okay. I don't see any raised hands.
So there's one question in the chat.
Yeah. All right. Okay.
Just to say, does every patient wish to follow a treat to target approach? So I think this comes back to treating patients as an individual. So we do apply treat to target to everybody, and we do the questionnaires and we do the full assessment, and I discuss that with the patient. Some patients don't want to keep changing therapy, particularly the patients like you just mentioned who have tried lots of different drugs and are struggling. They may find a drug that's the best that they have ever been, but they're not quite in a target. And that may be a perfectly good compromise for them. So it's a little bit like Dr. Howler's lovely quote that she used at the end about having a wish and a goal. I think it's important to have treat to target as a goal, but that doesn't mean that you always follow it blindly. I think we still need to discuss with the patients.
Yeah. Okay. Yes, there are raised hands. All right. Ahmed. Okay. The mic is yours. Ahmed. Okay, there is a question from Suzanne Abdullah. There are raised hands, but I could see 2 raised hands. Okay, you may write your question for those who are raising their hands. The sound is not connecting. There are 2 participants. They decided to raise question verbally, but the sound is not connecting. You can write your question. Ahmed, no question is written.
Please accept our request to share your camera and mic when you receive the request. Otherwise, we will not be able to hear you or see you.
We can't hear you. We can't hear any question.
Maybe if they want to put the questions in the chat, we can reply in the chat if that helps, because we might otherwise be running out of time. But
yes,
I'll keep an eye on the chat box for now, and we can maybe answer the questions in the chat or in the discussion at the end.
You may write your question, dear audience. You may write your question in the chat. Nothing. Ali is typing, but please the control, if you may, enable the mic from the participants. All right, from Jack, Dr. Laura, I'm aware of your trial on increase the Humira dosage to weekly dose to achieve MDA. Do you practice it?
So I think this relates to the control study. So the control study was an AbbVie-funded multi-center trial, which looked at comparing escalating methotrexate to adding in adalimumab with the aim of achieving MDA, and showed that adalimumab was superior to escalated doses of methotrexate. In the second part of that study, the second phase, those who had not achieved MDA on standard dose of adalimumab were allowed to double the dose, and that did to some degree improve the chance of achieving MDA in a significant minority of patients. I don't practice it locally because I can't get it funded. It's not that I wouldn't do it. I think there's a reasonable amount of data on weekly adalimumab from some of the older trials. There's not been any significant safety risk identified, so I would consider it as a trial if patients have not responded to the standard dose, but it's not something that I'm allowed to do.
All right. There is another question. A 50-year-old patient with the history of mastectomy for cancer breast 3 years ago. Show what? The letters are all connecting.
Yes. There's somebody who's been diagnosed with axial spondyloarthritis.
Yeah, with ankylosing spondylitis. Which biologic you suggest?
So really at the moment, for axial disease, we have TNF, IL-17, and maybe soon we have JAK inhibitors. So in that case, I would use an IL-17 probably over a TNF inhibitor in somebody with a history of cancer, but it would need a very careful and open discussion about the potential risks. I think the risk is relatively low, but it's something that the patient should be made aware of.
And there is also by Ali a comment rather than a question. Nail involvement is not counted also dactylitis in MDA.
Yeah, so you're right, nail involvement isn't included, and that is perhaps an issue in a small number of patients if they have very significant but isolated nail disease. The dactylitis measures weren't included as a specific extra measure, but obviously dactylitis is tender and swollen joints. If you have a dactylitic digit, you have 2 or 3 tender and swollen joints, so it would be picked up by the tender and swollen joint count in MDA.
All right. Any further question? I could see no more than those 3 questions. So thank you very much for you, dear speakers. And we will move to our next session and our next speaker. Dr. Rayan Saleh Al-Fadda is a consultant rheumatologist in the Department of Medicine at King Faisal Specialist Hospital and Research Center in Riyadh, Saudi Arabia. He's also was granted his 2 clinical fellowships, systemic lupus erythematosus and rheumatoid arthritis from University of Toronto, Canada. He is the program director of adult rheumatology fellowship at King Faisal Specialist Hospital in Riyadh, and provide teaching and clinical sessions for Al Faisal University medical students. Also, Dr. Rayan has published several scientific papers. He's going to present the next session together with Prof. Helena Marzi Ortega, consultant rheumatologist, University of Leeds Hospital. Our next session will be assessment of lost the slide. Yeah, assessing and diagnosing axial disease. You may start, Dr. Rayan. The mic is yours.
Thank you so much, Dr. Fahda. It is my pleasure to participate and give this talk. So I will be sharing a case with you that is puzzling, difficult to manage, and perhaps I will share with you some data in relation to the clinical case. So we have a 37-year-old gentleman who works as a military guy. He was labeled or diagnosed with ankylosing spondylitis in 2013 based on history of inflammatory back pain and lumbar spine restriction. His HLA-B27 was positive. This is his X-ray showing, as you can see here, bilateral, somewhat asymmetric sacroiliitis. Sorry. So he had poor response to non-steroidal anti-inflammatory drugs. Eventually, he was started on etanercept for 2 years, from 2013 to 2015. And then he developed anterior uveitis in the left eye, shifted then to adalimumab, and he was on it for 2 years, from 2015 to 2017. Then, as you could see just now, that he developed plaques on the soles and palms, and diagnosed with palmoplantar psoriasis with nail involvement as well. And then he was started in certolizumab. And the question really remains that is, as you can see, is this patient having ankylosing spondylitis with psoriasis, or whether it is from the beginning psoriasis and psoriatic arthritis with axial involvement, or whether this is simply psoriasis that is induced by the anti-TNF. So we'll share some data and see if we can help answering these questions. So first of all, for our colleagues in other specialties, referral and detection of axial involvement is important in patients with psoriatic arthritis. And in this study, it was found out that patients who have chronic back pain at the age of onset below 45 years, with if you ask them these 3 questions: buttock pain, improvement by movement, which denotes inflammatory back pain, and psoriasis, it was found out that if at least two of them are positive, referral to rheumatologist is warranted. If only one or less, and you still suspect axial involvement, you examine the HLA-B27. If it is positive, you refer them to a rheumatologist. This detects 80% of the patients with a specificity of 75% for axial PSA. Now, the prevalence of axial involvement in psoriatic arthritis varies. In long-standing PSA, it is estimated from 25 to 70%. In early PSA, it is somewhat between 5 and 25%. It is isolated. It happens isolated in about 2 to 5% of patients. Most of the time, however, I have to say that if you find axial involvement, it will be overlapping with other patterns that of psoriatic arthritis. Now, the inflammatory back pain is the important or cardinal symptoms for suspicion of axial involvement, especially younger age, insidious in onsets, and improves with exercise, and no improvement with rest, and pain at night that improves upon getting up and when the day starts. So another important aspect to recognize in these criteria is that they often they are good in classifying patients, but for diagnosing, maybe they have a little bit shortages, which, as you can see in this study, which looked at patients, around 200 patients of ankylosing spondylitis and psoriatic arthritis, and in about 1 in 4 patients fulfilled criteria for both conditions. So this highlights the importance of your clinical opinion regarding the patient, whether it is ankylosing spondylitis or psoriatic arthritis. Now, there has been genetic overlap, but it is very little, despite sharing several clinical features between psoriatic arthritis and ankylosing spondylitis. The HLA-B27 is the only genetic risk factor common for both diseases, and axial disease in psoriatic arthritis is actually more associated with other HLA genes than with HLA-B27. As you can see here in the picture, HLA-B39 and 38 is more involved with axial involvement in psoriatic arthritis. Also, in the psoriasis complex, HLA-C06, for example, is associated with early onset psoriasis and long psoriasis to arthritis latency and family history of psoriasis and more extended skin disease, as opposed to HLA-B27, which is associated with early onset of joint disease and short psoriasis arthritis latency with more axial involvement, dactylitis, uveitis, male predominance, and poorer prognosis. Important to mention that HLA-B27 recognizes or is associated with more radiographic damage in both ankylosing spondylitis and psoriatic arthritis with axial involvement. And the importance of this is upon detection of HLA-B27, perhaps more stringent screening for axial involvement and aggressive management should be started. Now, coming to the risk factors for axial involvement in patients with psoriatic arthritis is for early axial involvement, the risk factors are HLA-B27, radiographic damage to peripheral joints, and increased ESR, whereas late axial involvement risk factors are nail dystrophy, higher number of radiographic damaged joints, and the presence of periostitis, as well as increasing ESR. Surprisingly, family history of psoriatic arthritis reduced the axial disease risk early in the disease course. Now, this study looked at this question: is axial psoriatic arthritis distinct from ankylosing spondylitis with and without concomitant psoriasis? And it was found out that ankylosing spondylitis patients were 15 years at least younger at the first manifestations of arthritis and first presented to the clinic 7 years earlier. They have had much higher male predominance and were 4 times more likely to have HLA-B27 positive, and they had worse axial disease compared with axial PSA, whereas axial PSA was associated with a worse peripheral arthritis. Also, they were found to be more back pain at the presentation and worse disease activity scores, worse back metrology, and physician global assessment were more likely to be treated with a biologic. Those are the patients with ankylosing spondylitis. Also, in ankylosing spondylitis, the grade of sarcoidosis was worse than what you can find in axial PSA. This is a beautiful image that was presented yesterday by Prof. Helena, showing or summarizing the differences clinically and radiographically between ankylosing spondylitis and the left side of each domain or picture as compared to the right side, which shows psoriatic arthritis phenotype. As you can see, in psoriatic arthritis axial involvement, there is more frequent cervical spine involvement and non-marginal, chunky, large syndesmophytes. And in axial PSA, there is less syndesmophyte symmetry. Also, clinically, the higher frequency of inflammatory back pain was associated or seen in ankylosing spondylitis more than axial PSA, and they were more likely to be AS patients as compared to axial PSA were younger, with less peripheral arthritis and worse metrology. As compared, as I mentioned, more peripheral arthritis in axial PSA and older age at presentation, and low frequency of inflammatory back pain, which makes it difficult to detect and characterize those patients. Now, there has been many studies looking at this phenomena, where, as you can see here, many patients, or around 30% of patients who have radiographic evidence of spondylitis or sacroiliitis, lack the symptoms of inflammatory back pain. So clinically, they won't complain of inflammatory back pain. This has been shown in multiple other studies. This study looked at the characteristics of underdiagnosed axial PSA, and so that patients who have axial PSA by imaging only have more peripheral arthritis, suggesting that the severe peripheral symptoms may be a risk factor to mask spinal features of PSA. Over 3 decades ago, studies have looked at how the patients with axial PSA behave as compared to ankylosing spondylitis. And in this study, where they found that the patient with axial PSA have asymmetric sacroiliitis, non-marginal syndesmophytes, which are asymmetric, and more frequent involvement of the cervical spine with paravertebral ossification as well. Now, do the radiographic changes of classic ankylosing spondylitis differ from the changes found in spondylitis associated with inflammatory bowel disease, psoriasis, and reactive arthritis? And again, it was found that PSA axial disease is more involvement in cervical spine, with again difference in desmophytes, fewer symptoms, again with less symmetry and less involvement of the sacroiliac joint, and less HLA B27 positivity. So multiple studies have been consistent in sharing or showing us the same findings, that these patients are different than patients with ankylosing spondylitis. Coming back to our case, to see if that can help us, we said that cervical spine and syndesmophyte can help us tell if this is more likely to be ankylosing or psoriatic arthritis. Unfortunately, the X-rays did not show any significant changes, such as syndesmophytes or significant cervical spine involvement. As you can see here classically on the left side of the screen, this is what you find in axial PSA, where there will be a large jug handle-like or large volume chunky osteophytes that are asymmetric and do not appear on consecutive vertebra as compared to ankylosing spondylitis. And sometimes you don't see, or the sacroiliitis will be asymmetric. So following up the case, the patient later on came with Achilles tendonitis, more peripheral arthritis, ankle arthritis, and ongoing inflammatory back pain, and cetrizumab was then said to be failed to control the disease, and on a background of 25 milligrams of weekly methotrexate, tofacitinib was added, 5 milligrams BID. Despite that, his skin, peripheral joints, and back pain did not improve, and he was shifted to ustekinumab in April 2018. Again, when he came a few months after that, he had persistent active disease in multiple domains, including peripheral arthritis, skin and axial arthritis, with MRI showing active bilateral sacroiliitis more on the right side, and so he was put on secukinumab at that time. Now, it is important to see, and upon evaluating your patients, assessing what domains are involved. And for example, in this patient, skin, peripheral arthritis, and axial involvement, I would go with NSAIDs, then biologics, TNF, anti-IL-17, and then possibly switching therapy. This will be my approach because it will cover all the domains in treatment. Again, this is just to show you that you should not go, for example, for this patient who have predominant axial and peripheral and skin involvement, no indication for synthetic or conventional synthetic DMARDs, especially for the axial involvement. Now, the outcome measures for axial PSA are lacking, and no specific measures for axial disease have been accurately developed, and most of the outcome measures are borrowed from ankylosing spondylitis, including the BAS-DI, ASDAS, BASMI, and BAS-FI scores. This study looked at the best discriminating factors between patients with psoriatic arthritis with axial involvement and without axial involvement, and found out that the BAS-FI, which is the Bath Ankylosing Spondylitis Functional Index, best discriminated between those patients with axial and without axial involvement, followed by the modified Schober test, lateral lumbar flexion, and slightly followed by the BAS-DI score. And perhaps exclusion of question 3, which refers to peripheral manifestations in the BAS-DI scores, improves the performance of that scoring, especially when you consider treatment or changing treatment. So in May 2019, he was still on secukinumab. He had still active skin disease and nail involvement as well. Despite stopping the anti-TNF, his psoriasis did not improve. He was also on topical treatment and oral retinoids with somewhat improvement in his in his skin and nail changes. However, his peripheral arthritis and axial involvement continues to be bothersome. Ultrasound in the clinic showed tenosynovitis in multiple digits. And so for the suboptimal control, it was planned by dermatology for guzelucumab. He was reluctant because he was afraid, the patient, that he will lose the relative improvement that he got after starting secukinumab, after trying many biologics. According to him, this has helped the most. And then for persistence and continuous symptoms, he was started in December 2020 on ixekizumab. And still, despite that, he is suboptimally controlled with increasing frequency even to the maximum. This is his latest MRI in June in this month, showing still persistent active disease with bone marrow edema, sclerosis, and secondary changes, secondary degenerative changes. Also, post-enhancement studies denotes that he is still having active disease. And my final remarks in this talk, I'm wondering with you, should axial PSA be defined in a similar way to ankylosing spondylitis, requiring radiographic and clinical evidence of disease, or based on radiographic evidence of disease only, based on what I presented before? And the development of specific indices and biomarkers for the clinical assessment of axial disease in PSA and the separation of this domain from other domains will help pinpoint the exact effect of different therapies on the axial component of the disease. And this is my last slide. Thank you. We cannot hear you, Dr. Fahda. The mic is muted.
Can you unmute me, please? Why am
we can hear you now, yeah.
You can hear me now, okay.
Yes.
All right, I just would like to ask all our participants to start preparing their question and write them down in the chat box to save time at the end of the presentation, okay? Prof. Elena, the mic is yours.
Okay, well, thank you very much for this. I don't have such a comprehensive talk as the one we just heard from Dr. Rayam, which was very much a whistle-stop tour of everything that we understand nowadays as per axial psoriatic arthritis. But I do have a few cases, and I thought perhaps, the best way of doing this could be to have it as interactive as you like. So please feel free to, put your hand up or write on the chat, and we'll be addressing questions as we go along. What we've heard now is a very nicely presented insight into what we understand for axial PSA these days. But as Dr. Rayam was alluding to, clearly we are struggling, first of all, to recognize it promptly and accurately, and also to assess it. So I think at this moment in time, we are still very behind as to how, or what, if you like, should be the tools that we need to have in clinic. Yeah. So, for instance, definitions of a back pain as such are not as specific in the context of axial PSA when compared to axial SPA, and this has been published in at least two different studies recently. And also, when we do imaging, we're still not I mean, how would I say, we don't have an imaging technique that is sensitive enough. So we know that X-ray helps, but X-ray takes a very long time to show abnormalities. It's very much based on calcium, penetrance and imaging, and that takes years, to become visible. Now, when we look at MRI, again, we discussed yesterday, you may remember that it may be only 30–40% of patients who have got active pain in the context of psoriatic arthritis, active back pain that is, that may actually show something on the MRI. So let's have a look and see at these cases and see what you think. So this is a 35-year-old gentleman, and this is a real case, the same as the one that has been presented now. And he came to us with a 6-month history of back and neck pain. And the history was quite a mixed patch, as it often happens. Yeah, so it did not completely tick all the criteria for inflammatory back pain. There was no peripheral joint involvement. He had tried with some anti-inflammatories, which only provided mild relief. It had helped a little bit with a stiffness, but not much beyond that. And on the family history, he remembered one of his grandfathers, the one on the maternal side, having had psoriasis. He had not seen the psoriasis practice himself, but he heard somebody about this possible family history. So when we did investigations, these weren't very helpful at all. And I'm sure that you will all recognize this as something that you see in your clinics. So the CRP was less than 5. The rheumatoid factor was negative, and the HLA-B27 status was negative too. So we did some conventional radiographs, and this is what we found. Okay, so we got a lumbar spine and an SIJ X-ray, and that's usually something that we do routinely in our department when people present with low back pain. Sometimes we request a pelvic X-ray when we want to have a look also at the hip joints. But if you request an X-ray for the purpose of identifying the possibility of sacroiliitis or lumbar spine involvement, the radiologists usually like to perform this view. Okay, so any comments on this X-ray? And I'm only giving you the AP, I'm not giving you the lateral. Any comments here? Anybody would like to say something? I know there is 112 of you out there. Okay, so, I mean, you could be excused from thinking that this is quite a normal looking X-ray from this side, and I think I could agree with you. I mean, the sacroiliac joints are, clearly largely patent, so there was not much to be said in that area. And also, if we look at the sclerosis-wise, perhaps a little bit on the left side, but not really very exciting at all. I'm hoping you can see my cursor, by the way. Okay, so what are your thoughts at this stage? Now, how many of you would say that this could be an axial psoriatic arthritis? How many of you would say that this could be an axial spondyloarthritis, or could this just be a case of mechanical back pain or perhaps degenerative spinal disease? I don't think we've got this set up as a poll. Oh, yes, we do, okay. No, this is the one from yesterday. We probably don't have a poll now, but it doesn't matter. If anybody would like to just say something, that would be great. Okay, so let's move on. So I think this very much depends on which side of the fence you are sitting. Now, a lot of you would be thinking, well, it's got to be axial PSA because this is what the session is about. But a lot of you would be thinking, well, I don't think this story or this history, if you like, is completely specific for any particular diagnosis. And I would agree with you. So let's go through it then. If we think about the possibility of this being within the psoriatic site, we look at the Casper criteria. So we know that for Casper criteria, a patient must have an inflammatory articular joint disease. And this could be either on peripheral joints, on the spine, or at the enthesis. There needs to be at least 3 points from these categories. And the categories include the presence of current personal and family history of psoriasis. But of course, the one that really adds weight is the presence of current psoriasis on the patient in front of you. Now, nail dystrophy matters is a very specific finding in the context of true psoriatic arthritis. Negative rheumatoid factor is something historical that we've inherited from previous observations when the differentiation between seronegative rheumatoid arthritis and seropositive rheumatoid arthritis was based on the presence of rheumatoid factor. Now we know that this antibody is not as specific, and that CCP positivity is where the importance lies at the time of diagnosing rheumatoid arthritis. But the whole idea of using it in the context of psoriatic arthritis was to make the difference that it did not have the same serology as rheumatoid arthritis. That's the reason why it was included on the Casper criteria. Now, dactylitis is another very specific lesion in the context of psoriatic arthritis, perhaps more so than in the context of the rest of the spondyloarthritis. And the other marker of the criteria is the presence of radiographic just articular renewable formation. And we know that in the majority of patients coming through the early arthritis setup, psoriatic arthritis with short disease duration will rarely have the presence of juxtaarticular new bone formation. But again, you are able, or the criteria performs in very early disease without the need for the patient to fulfill the particular radiographic criterion. So in this case, our patient had a history of inflammatory, if you like, spinal disease, and there was a family history of psoriasis, as well as negativity for rheumatic factor. We cannot apply ones and the others because there was nothing on the x-rays and there was no nail involvement. So this means the patient had a 2-point on the Casper criteria, which means that he fell short of the target. So according to this criteria, he could not be classified as having officially psoriatic arthritis. Okay, so we go back to the old chicken and egg question that, again, Dr. Ayab has alluded to. What is the difference between axial psoriatic arthritis or axial spondyloarthritis with skin psoriasis? So a lot of you could be sitting on the fence of the axial criteria and could be thinking, well, surely we can classify this patient according to this ASAS criteria. So in this case, the patient was actually B27 negative, so we cannot follow the clinical route. We have to go for the imaging evidence of disease. So in here, the weight really goes on the presence of sacroiliitis. You can find this on X-ray, you can find it on CT, you can find it on MRI. But when we have very early disease, of course, we know that X-rays and CTs may not be that relevant. And what we look is for sacroiliac joint inflammation. And that's what the definition, or the ASAS definition, if you like, of a positive MRI alludes to. But in this case, I'm not showing you the X-ray of the SIJ, but you have to take my word for it that it was completely negative. However, as you can see on this MRI of the spine, there were some lesions on the lower spine and lower thoracic area. So this is a sagittal view. On the left-hand side, we've got the T1 sequence, which is fat sensitive sequence. And on the right-hand side, you've got the T2 spare sequence in which we have removed the presence from fat. So you can see here, okay, how these lesions are actually highlighted. And that corresponds with acute bone marrow edema lesions. So does this patient fulfill the ASAS classification criteria? Well, again, the definition, as I've just said, alludes mainly to the presence of sacroiliitis. So although we do have some lesions that we can identify on the spine, the definition of a positive MRI for classification of axial SPA still to these days continues to depend on the presence of active sacroiliitis. And the reason for that is because we do not have enough data as to interpret lesions that occur solely on the spine. And if you think about it, 30% of individuals with axial PSA will have isolated spondylitis. Less than that, probably 15% or 20% with axial SPA will have isolated spondylitis. So what this is telling us is that all these criteria can help when they help. But the majority of the times in the context of axial PSA, they are not helpful. And the reason for that is because axial PSA does not behave in the same way. It does not have sacroiliac joint involvement necessarily. It doesn't have high inflammatory markers as often. It tends to be primarily B27 negative. So in these cases, what you have to do is you may err or you may not be able to fit a classification criteria, but you have to apply your clinical acumen. And remember that the diagnosis to this day, both for axial SPA and for axial PSA, remains clinical. So again, only 35% of PSA patients may have isolated spondylitis with no sacroiliitis. And as we alluded to yesterday, 80% of your axial PSA patients will be HLA-B27 negative, with only a minority, a quarter of them, being HLA-B27 positive. And it's usually this subgroup, okay, of axial PSA that will be classifiable according to the axial or the AXPA criteria. And in those scenarios, you could think about treating the patient or escalating therapy following the primary back pain route. So, any questions up to now? We have, I have only a few cases, but my idea was to discuss them with you and to get questions from you. So I don't know whether you're going to find them interesting enough.
Not much questions so far related to the case you've presented. We can proceed.
Okay, so this is another little case. 30-year-old gentleman, 2-year history of inflammatory back pain, had already been treated with anti-inflammatories by the time they came to clinic, and he did have a childhood history of psoriasis. He was B27 positive, rheumatic factor negative, and he had a mildly elevated CRP. And this is what his X-ray showed. So compared to the patient that he has presented before, yeah, we can see that there are some differences here. If you look at the sacroiliac joints, okay, these are still patent, but perhaps more so on the right than on the left side, where there is quite a substantial amount of sclerosis and possibly some early bony breaching in the lower side. But when we look at the lumbar spine, that's where the differences are more striking. And you can see here that there is already the presence of breachings in desmophytes. Now, the first thing to look or to think or consider here is this is a 30-year-old with a 2-year history of inflammatory back pain. And my first move here would be to go back to the patient and try to really elucidate the disease duration, because I find very difficult to believe that only within 2 years you're going to be able to develop this type of abnormalities. However, we have some pointers. He's B27 positive, and he already has some evidence of inflammatory disease or objective inflammation with his CRP, suggesting that he probably belongs within the poor prognostic spectrum, meaning that he's more likely to progress over time. So this is a case which is very similar to what you would encompass in an axial SPA setup, and the sort of situation in which you want to escalate therapy quickly. Because if you take data that comes from the axial SPA literature, we know that B27 is a predictor for response, as is the presence of a high CRP at baseline. Yet, we also know that the presence of baselines in desmophytes is a poor prognostic factor, suggesting that disease here is likely to be severe. So this whole case will be pointing towards the need to treat early and to treat as aggressively as possible. So this is another case. This is a 30-year-old female. Very similar history, 2-year history of inflammatory back pain, particularly problematic in the neck. Now, there was a good response to anti-inflammatories. She had tried many by the time she came to see us, and she had a family history of psoriasis rather than a personal history and previous plantar fasciitis. And when we did her serum investigations, we found that she was B27 negative, rheumatic factor negative, and that she had a normal CRP. And this is what her X-ray showed. So all these are real cases, and you can see the difference between them. So the first one, or the one I've just shown you now, it was another 30-year-old male. He was B27 positive. He had a mildly elevated CRP. This is a 30-year female, very similar history, around 2 years or so, perhaps a little bit more, but she was B27 negative, CRP negative, more or less similar disease durations. You may argue that there may be a little bit of a squaring in this part of the vertebra. Typically, axial PSA will have abnormalities on the posterior part of the vertebral bodies and on the posterior processes. But other than that, you can see there is nothing anteriorly, not much at all. Yeah, and if when we look at the SIJs, it's the same, a little bit of sclerosis, but really very much patent SIJs. So then the question here would be, can you first classify her as an axial PSA patient? Well, she probably could not fulfill criteria for Casper. She's not fulfilling criteria for axial SPA. And you also have all these medical conundrums. Her CRP is low. Her HLA-B27 is negative, as you would expect anyway, on the majority of the axial PSA cases. So do we have much evidence that treatment is going to make a huge difference here? Well, we don't have that evidence coming from the Axial PSA literature, but we do have evidence coming from the Axial SPA literature that tells us that in the presence of a normal CRP, you are less likely to have good treatment response. This together with absence of bone marrow edema on MRI. So I did show you this slide yesterday, and it's just to remind you that MRI may not give the answer in every case. When you do MRI in patients with psoriatic arthritis and peripheral joint involvement who have a high VAS dye, a high VAS, you may not have more than 30 to 60% of findings or situations in which there will be a positive scan. This is in contrast to patients with axial SPA, where the majority, up to 70%, may actually have a positive MRI. But it is clear that in this subset of axial PSA, where we find HLA-B27 status, that it's clear that this subset tends to be more severe, if you like, and they tend to behave more like axial SPA. So as we said yesterday, B27 matters clinically because it's giving us information as to the extent, the severity, and possibly the persistence of back involvement in our patients with psoriatic arthritis. And this is a scan from a patient with axial SPA. You can see a lot of posterior involvement, posterior element involvement, who had a normal sacroiliac joint. So clearly, disease here is present. In this context, you would be well advised to make a clinical diagnosis of psoriatic arthritis and start treatment as you see fit. So those were my cases for now, and I would be very happy to take questions. And I think the important bit here is that you guys come up with the questions so we can see whether you agree or not with our understanding of axial PSA. And I think we have one here. I don't know whether we've got a moderator, but Dr. Ryan, are you happy we take this question? So this is somebody asking about a patient with latent TB.
Yes,
who had
sure.
Positive gamma interferon, normal chest X-ray with psoriatic arthritis. How long do you recommend to give prophylactic isoniazid before giving secukinumab?
Thank you.
Okay, excellent question. Okay, so that's okay.
Sorry, I was disconnected. Sorry, yeah.
Not to worry, we thought we would get ahead
well,
with it.
Okay, you got a very nice question, the prophylaxis TB.
Okay, well, I can tell you what we do in the UK. I mean, secukinumab definitely has got a much favorable data towards TB when compared with the TNF inhibitors, for instance. But we send everybody with a positive quantiferon that suggests that there may be latent TB. We send them to the chest clinicians. And if active TB is excluded, we will always be considering at least 1 month prophylaxis before we start the biologic. And we like to be cautious, and we do have some clusters of population in certain areas, particularly in West Yorkshire, where we can find these latent TBs. And we will give prophylaxis for a month, and then we tend to complete a 6-month course once the patient has started on the biologics. So we run 4 or 5 months alongside. But usually that is average. It depends on every case. I'm not sure how you guys manage this in the Middle East. You want to tell us?
Yes, sure. So probably more or less the same. It's not as so. Every patient who has a latent TB, you have to exclude active TB first, and then a prophylaxis with INH should be started 2 to 4 weeks before starting the biologic. Now, with the anti-TNF, I would be more careful. However, with the anti-IL-17, we still do the same. However, we've had some difficulties in some of the patients, and we came across a few case reports, especially from the dermatology literature, where the patients with plaque psoriasis who had, for example, there was a case series of 12 patients with the patients who, those patients had plaque psoriasis with latent TB and had contraindication to chemoprophylaxis with INH. And none of them received INH, and they started secukinumab, and for a period of 52 weeks, they were followed with no reactivation of TB. So probably maybe a little of that we know, but maybe it is not as a risk factor for reactivation as anti-TNF, but still I would keep recommending starting chemopro 2 to 4 weeks before initiating secukinumab.
All right. To the audience, our dear participants, I still receive some of them asking for the mic to raise question themselves. I said it earlier, please prepare your question in writing in the text in the chat box, okay? There is a question about your first case. Will you use biologic? And if yes, which one you prefer?
Which one is it, for Ryan or for myself?
For you, in the case you presented. Yeah.
Yes, on the first one, yes, definitely. I mean, I would use a biologic. And I think at the moment, because there is so much uncertainty as to how to classify these patients, we just make it to our advantage, to be fair. I mean, one of the questions I was going to ask Ryan is, does it really matter that we diagnose axial disease early in a patient with peripheral joint involvement in the context of psoriatic arthritis? If we're going to treat them anywhere with biologics, okay, we like to characterize the disease, the disease phenotype of each patient we've got in front of us. I call it mapping the disease. Yeah, I like to map the disease. I like to know what my phenotype is. Do we have nail involvement? Do we have enthesitis? Do we have axial disease? But at the end of the day, if we do have peripheral joint involvement, we are able to treat aggressively quite soon. Okay, and we know that certainly in the UK, because we are sort of going down the route of the biosimilars first because of cost implications. We know that TNF inhibitors are good all-rounders. Yeah, the situation in which we need to know whether the back is the primary involved target is when the peripheral arthritis is not that clear, when there is no swelling, or when there is enthesitis, for instance. In those cases, yeah, we really want to be able to escalate therapy quickly. And ideally, we would like to have ammunition that the patient has got axial disease, so we can follow the axial route and bypass conventional synthetic DMARDs. So I think at the moment, we are all very clinical clinicians, and we are treating what we have in front of us, and that's what we should be doing. We don't want to become too restrictive. But for the purpose of imaging, I don't know. What do you guys think?
We'll see. There is a question for you, Prof. They said, is there an explanation for the different order of involvement of sacroiliac joint and spine? And the negative HLA-B27, does this mean that we may need to try another drug approach?
Okay, that's an excellent question. I don't think it means we need to try another drug approach. I think it means we need to understand what are the drivers. Okay, so for instance, at the genetic level, there are many genes that take part. There was a nice study done by, I think it was Winchester about 6-7 years ago, in which, they were trying to dissect the phenotype based on the genotype, and it was clear the difference, between the peripheral joints and then physical and more axial, involvement, and the gene drivers were different. And as I say, B27 doesn't help in the majority of the cases. If you are in Africa or in the Southern Hemisphere, the prevalence of B27 is very low anyway. So it's not going to be that helpful, yeah? But the question is, we really need to know what is driving, this type of presentation. And once we know that, we will be able to apply the precision approach, with drugs. But so far, we have to use what we've got, and we know that in the context of psoriatic arthritis, we have drugs that work, within the different tissues affected. But answering the question about the asymmetry, that's an excellent question, and it's got to be related to the biomechanical strain on this, that is so typical in these diseases, and it's typical, for instance, that the problems start on the lower limbs, and one has to think it's got to be associated to weight, to the loading, that the axial skeleton does, and why one side more than the other is something that is not completely well elucidated. But it's definitely not a symmetric disease by any means.
Thank you both of you. Excellent session, and we conclude here, and we'll move to the next session. Thank you very much.
Okay. Assalamu alaikum jami'an. Good afternoon, everyone. I'm Ahmed Al-Hazmi. I'm a consultant rheumatologist at King Fahd Armed Forces Hospital here in Jeddah, at the western region of Saudi Arabia, right by the coast. And I'm in charge of the training program, rheumatology fellowship training program in the western region of Saudi Arabia. Well, it's very exciting event. In fact, started last night and continued this afternoon. And we, in the following session, it's going to be the last session. The remaining domains of the SPA are going to be addressed by our distinguished speakers. We'll start off with it's one of the domain of the SPA, of course, but it's considered to be the pathologic hallmark of the SPA group, with the SPA disease. That's the enthesitis, and is going to be presented, and then by Dr. Basant Al-Nadi, who's a consultant rheumatologist at King or the Al Hospital in Al-Hada, Taif, Saudi Arabia, who's also a professor of Banha University in Egypt, and she's a certified musculoskeletal ultrasonographer. Dr. Basant also is the program director at of the Rheumatology Fellowship Program in Al-Hada Hospital, and she has published several articles, studies, and literature, and she's quite active in the field of rheumatology here in Saudi Arabia and also in Egypt. Dr. Nada, her speech is going to be followed by sharing some cases, as this is supposed to be, or actually it's a workshop. So by Professor Dennis McGonigal, and I hope that I pronounce his last name correctly, who's a professor at Leeds University. He's also honorary consultant at the Leeds and also Hospital, UK. He's a part of GRAPPA and ASAS, and he has several publications in the field of the Spondyloarthritis group. Please, for the audience, you still have the option to raise your hand and ask the questions at the end of the session. So, Dr. Basant, Prof. Dennis, the mic for you for the next, I believe, 40 minutes or so. We're a little bit behind the schedule, but we will manage. Thank you.
Thank you, Mr. Chairman, for the presentation. I'd like to thank the organizing committee as well as Novartis company for inviting me to this scientific meeting. Also, it's an honor to share the session with Professor Dennis McGonigal. I hope I pronounced it right correctly, me too. So I will talk about the enthesitis in brief. So we will go a little bit about the pathogenesis of enthesitis, because it's almost covered yesterday by our colleagues' sessions. We will mention the limitation in clinical assessment of enthesitis and how to overcome this limitation with imaging modality. And also we will highlight the updates in management and recommendations. So enthesis is a Greek word that means insertion, and the pain at the site of insertion means enthesitis. However, recently, enthesis is not just like an insertion site, it's an organ complex composed of the tendon, bone, and fibrocartilage. It's a pathognomonic feature in case of SPA. It's could be found from 35 to 50% in those patients, and it could be only the isolated feature in those patients with functional disability. So the mechanism of enthesitis for SPA or PSA is still unclear. However, in case of mechanical enthesitis like tennis elbow or golfer elbow in healthy individual, chronic mechanical stress could be the cause. And with the hypothesis of Kopner phenomena in PSA, the mild mechanical stress can induce inflammation, could be the cause also of enthesitis, specifically with those with high body mass index and younger age. This nice cartoon I have been adopted from a nice article by Professor Dennis and his colleagues published in Nature Review of Rheumatology, and it summarized the pathophysiology and the underlying immune response in case of enthesitis. I hope you can see my cursor, and the involvement of the innate immune response in this pathogenesis with prominent interleukins like IL-17, IL-23, and TNF, with active mesenchymal proliferation and end with the new bone formation of the enthesiophyte. In clinical practice, we have a limited use to the available scoring system. Usually, this scoring system has been used only for clinical trial to assess the response of medication. Three most common scoring system has been used, like the SPARC scoring system, which has been illustrated in this mannequin, and lead enthesitis index, which more simple, like lateral, humeral epicondyle, medial, femoral epicondyle, and the Achilles tendon, and the maze scoring system, which assess mostly up to 65 entheses in the axial skeleton and only the Achilles tendon as a part of peripheral skeleton. However, the differentiation of underlying different pathology like avulsion injury or tendon rupture or even tendon tear cannot be elicited easily with this scoring system, and its use in clinical practice, as I've mentioned, is limited. So we have two phases of inflammation in case of enthesitis, either the early inflammatory status or the structural stage. And I will share with you two cases representing each stages of the enthesitis. So this is one of my patients. She's 29-year-old. He's a 29-year-old male patient, teacher, labeled as juvenile idiopathic arthritis at the age of 7, treated with methotrexate and also bridging steroid therapy. And since that time, he was controlled. Came to the ER with bilateral posterior ankle swelling, represented bilateral Achilles tendinitis, and affecting his functional capacity, even though the patient came on a wheelchair. Regarding the history, no other history suggestive of other connective tissue disease. Also, no other history suggestive of other SPA features rather than plantar hyperkeratosis. This is the image adopted from the literature for the Achilles swelling, same as our patient. He has high PMI, bilateral Achilles tenderness, and plantar hyperkeratosis at this image. And he was referred to our dermatologist, who was suggestive of plantar psoriasis for biopsy to confirm. Regarding the lab result, all lab results were within normal, except a little elevation in ESR and CRP. Rheumatoid factor CCPNA all was negative. And until 1990, only conventional radiograph was the only technique commonly available or accessible for the clinician. And this is the X-ray for our patient, and as you can appreciate, no striking abnormality that can help us in his case. That's why searching of new, better modality is warranted. So MRI is an excellent modality. It can assist the case of inflammatory enthesitis at the inflammatory phase with fat suppression sequence stir image or T1 weighted post-gadolinium sequence. Also, T1 weighted pre-gadolinium sequence is helpful in case of structural changes. And here you can see in the cursor the picture of hyperintense signal at the site of the calcaneus representing osteitis, and this means we have inflammation at that site with also hyperintense signal at the site of the Achilles insertion and representing enthesitis in this patient. This is another MRI for a patient with plantar enthesitis showing osteitis at the site of the calcaneus, specifically at the site of insertion of the plantar fascia with hyperintense signal, same at the plantar fascia insertion. Those both image in the stir images. Recently, diffusion weight images showed a higher sensitivity than stir images in detecting early inflammation in case of psoriatic arthritis and PSA. Another important and commonly used modality is the ultrasound. Musculoskeletal ultrasound has been stated by OMERACT consensus a certain definition for enthesitis, both grayscale and Doppler. And this article is very interesting. I advise my colleague to read it. It published in the Annals of Rheumatic Disease 2018. And we will go practical on cases to show these findings on the ultrasound. So in case of early inflammatory status, patient with enthesitis usually will have on the ultrasound manifestations suggestive of inflammation like thickening of the tendon, edema, hypoechoic finding, in addition to synovial complex in the form of bursitis. One of the most sensitive finding in ultrasound, but not specific, sorry, not sensitive, but specific, is the Doppler signal at the site of enthesial insertion, which considered a part non-vascular. With hypervascularity at that site, it indicates an inflammatory ongoing process. Ultrasound also can distinguish the other pathologies as avulsion or injury or rupture rather than enthesitis. This is our patient that we have mentioned earlier. This is a plantar fasciitis, and you can see the hypoechogenicity of the plantar fascia insertion. And this is his Achilles tendon with edema, hypoechogenicity, thickening, microcalcification, and the retrocalcanean bursa. Retrocalcanean bursitis, and this image adopted from Professor George Bryan showing the characteristic Doppler signal at the site of enthesial insertion representing enthesitis, and also here around the retrocalcanean bursitis. What about structural changes and how can we assess? So she is a 33-year-old female patient, housewife, referred to rheumatology clinic with joint pain. No history suggestive of connective tissue disease, and this course of disease was inflammatory, progressive over 2 years, not responsive to non-steroidal anti-inflammatory drugs, and she was following with orthopedics for plantar pain. And upon examination, patient denied any history of skin rash. However, while examining her, there is a skin rash under the right breast, and she thought that like eczema or some allergic reaction as she thought. And she has high body mass index, bilateral wrist arthritis, bilateral plantar fasciitis, and bright patellar tendon insertion tenderness. And she has almost normal inflammatory marker on lab finding. This is her conventional radiograph. It's helpful here. You can find the calcanean spur and retrocalcanean spur representing the structural changes of enthesitis in this patient, which represent the chronicity and long-standing disease. Also, high-resolution CT, one of the new modality, has been found to have a higher sensitivity to detect very early new bone formation in case of psoriasis. Regarding this, her ultrasound in the clinic, you can appreciate the very large enthesiophyte and also the another enthesiophyte at the site of patellar insertion and at the site of the Achilles tendon with no obvious Doppler signal for her. This is another ultrasound for another patient in our clinic representing another structural changes in enthesitis, which is the erosions. So ultrasound is helpful to detect active enthesitis, chronic enthesitis, and also subclinical enthesitis. This is a multi-center study done in 2 centers in Saudi Arabia with my colleagues and I, and we have examined with ultrasound 109 psoriasis patient for subclinical synovitis and enthesitis. Those patients has been given a questionnaire to assess if they have musculoskeletal manifestation or not. All of them does not have any musculoskeletal manifestation in the history, and interestingly, up to 40% of those patients were having subclinical enthesitis and synovitis compared to 10% in normal population. Those patients were followed up for almost 2 years, and the annual incidence of psoriatic arthritis for those patients in Saudi Arabia was 4.3. And interestingly, we have found that baseline clinical synovitis and enthesitis was associated with development of PSA. So also, ultrasound can be helpful not only for the subclinical, but also for the treatment response for patients with PSA and SPA. So recently, the ultimate study using a randomized controlled trial between IL-17, secukinumab, and placebo to assess the response to the drug via ultrasound Doppler and global scoring system for synovitis, SPARC clinical assessment score for enthesitis as a secondary endpoint, and the another exploratory endpoint, which is enthesitis by ultrasound. So the first or the primary endpoint has been met. At the 12-week, there was a significant improvement in secukinumab arm with ultrasound scoring system in comparison to placebo. The secondary endpoint with enthesitis SPARC scoring system also has been met. And recently in the previous ELR, at the poster number OP0226 presented by Prof. Maria showed there is also improvement and response to secukinumab for enthesitis at the definition 1, which means both grayscale and ultrasound, with significant difference into placebo arm. However, there is no response regarding only Doppler signal, which could be related to the inclusion criteria lacking, including the patient with positive Doppler signal at the baseline of the study. So as we've mentioned with Dr. Khawler earlier, treat-to-target approach is one of the targets for all our clinician to apply to our patients. So it was advised by the three main societies, ACR, EULAR, and GRAPPA. And the most recent published or presented guidelines updates was the GRAPPA guideline in the EULAR by Prof. Laura Coates. And they highlighted the domain of enthesitis by using the NSAID, then biologic therapy. And the most important, the strength of the evidence was shared and agreed by the consensus that biologic therapy has the most strongest evidence to provide for our patients. So to conclude my talk, enthesitis is a distinct disease process with disability burden that can occur independently of arthritis. Enthesitis associated with low threshold mechanical stress, commonly in younger age with high body mass index. Clinical scoring system, easy to use but limited in clinical practice, which can be overcome by imaging modality to establish proper diagnosis distinguished from other pathologies. Musculoskeletal ultrasound is a valid modality to assess both early inflammatory and structural enthesial changes. And at the end, you should individualize management of your cases because enthesitis is a challenging topic or not easy to differentiate mechanical from inflammatory in clinical practice. And thank you.
Thank you very much, Basant. That was really excellent. First of all, I have to apologize. I often cite your work when I talk about psoriatic arthritis prevention and using imaging. And I just realized you are the Basant El Nadi of that very interesting publication. I wanted to ask you, you have a very high incidence rate of psoriatic arthritis. It was 4% each year. Was it 4% per year for 2 years?
Yes, almost 4%. Yeah, 3%.
That's very, very high. That was my major sort of concern or criticism of the study. How do you explain that?
Our study was the first in Saudi Arabia to assess the incidence, so could be the different ethnicity to study this group could be justification. Another thing, it's only 2-center study, so I think we need a higher number with the multi-center study to confirm these data.
Yeah, no, it's very good. Well done. It's good, really good work. Now, I'm just looking now for questions here. Do we see anything? Well, I can ask you. I wanted to ask you about the ultimate study. So you were saying that secukinumab did not show any difference in power Doppler, significant difference compared to placebo.
Yes, regarding definition 1 with grayscale and power Doppler both together, it show a high statistical significant difference and improvement. However, in the power Doppler alone as definition 1 show no significant difference. But there is no, in the inclusion criteria, if we go back to the ultimate study, the power Doppler in the enthesitis score as inclusion criteria was not there. So maybe we have not included a lot of patients already with power Doppler. As you know, it's high specific but not sensitive. And the different uses of machine all over different centers also can affect the sensitivity of Doppler signals. So this means that definition 1 was more feasible than definition 2 in this study.
So just to highlight, this is really important. If you have active rheumatoid arthritis, because the synovium is very vascular, you can see the target swelling and you can see the target on ultrasound. But entheses are relatively avascular and well innervated, so you can have active enthesitis with a lack of power Doppler. So there's nothing wrong with including patients without pre-specified Doppler. And I just wanted to highlight that, and I wanted you to address it with. Like in clinical practice, you may have somebody with clinical enthesitis, and you may not see much on ultrasound, right? Yeah, just to highlight that.
Yeah. May I ask you a question? It's in the clinical practice, it's difficult to differentiate mechanical from inflammatory. So do you have a specific criteria, the whole picture, inflammatory marker, or sometimes patient come only with isolated enthesitis? And those patients, honestly, I try everything, and at the end, I give trial of biologic, and surprisingly, they respond.
Yes, what you just described, I call this phenomenon the polymyalgiaization of spondyloarthropathy. And by that, I mean that when you're not sure about PMR, you give a trial of steroid. And it's the same idea. You probably can give a trial of steroid as well. I usually give an intramuscular and a depot, but yes, absolutely. And it is hard to tell them apart. And of course, as has been mentioned, and we've theorized that the mechanical insult drives inflammatory disease. So it's not as if mechanics are not relevant for what we considered historically a pure autoimmune disease. And many of the patients with inflammatory disease have obesity, joint malalignment, pes planus, etc., and they may also have an element of a concomitant mechanical pathology helping drive the immunological disease. So it's a huge problem. Yes, I agree. So when in doubt, treat. Yes, that's my position too. And you can't depend on imaging necessarily, because these structures are not vascular. So one of my concerns with an emphasis, because you cannot appreciate enthesitis clinically, you don't see the swelling usually. If you can't see the target, it's very hard to have a shot. So not being able to see your target is a very dangerous position to be in on a battlefield. And it makes enthesitis a very dangerous enemy to hit. Yeah.
Yeah, sure.
There's a question here. If a Primalist is effective in psoriatic enthesopathy, is there a difference between enthesopathy and PSA and Angst-Spond? So I'll just start and hand over to you. Of course, the Primalist has efficacy data for psoriatic arthritis. They did phase 2 study in Angst-Spond, I recall, but it wasn't great, so they never really developed it. So we've never really had a large study in Angst-Spond with the Primalist. But of course, we have the same argument could be raised about the IL-23 blockers. If they're effective in peripheral enthesitis and psoriatic arthritis, why aren't they effective in axial enthesitis in Angst-Spond? And outside of the SIJ, the whole bamboo spine is a polyenthesitis. I don't know why people don't say this, but it is. That's all you see. It's a polyenthesitis. So, yeah, what do you think of that question about being effective for peripheral enthesitis, but maybe not being effective for axial enthesitis in Angst-Spond? What do you think?
I think, yeah, as you've mentioned that yeah, the whole spine is a part of the enthesitis. Maybe on the mechanism, the efficacy of the drug itself has not been studied well on the axial spondylitis. Maybe this is maybe the threshold of the drug effect on the enthesitis in the spine also need to be adjusted with higher doses. Something I think need clinical trial to answer this question.
Are we out of time? Are we out of time, everyone? Yeah?
We're almost there, and I think you've already answered some questions. So at least we made the base of the workshop kind of environment here. So I think we're gonna move to the second session. But before that, I have a question for Dr. Basant and Prof. Of course, you would. Your comments will be definitely, and as it is always been additional sort of benefit. So now the ultrasound used to, the patient who has spondyloarthropathy or arthritis, we better call it itis, where they have enthesitis, the domain is also clinically apparent. So now, if they have coexisting fibromyalgia syndrome, so where some of the entities are actually the tender points of fibromyalgia. And even with ultrasound, I believe there was a study like a year or 2 years ago where they looked at a primary fibromyalgia patient, and they do have an ultrasonographic evidence of enthesitis or inflammation at the site of the usual site, maybe involved in both conditions. So, and here is difficulty comes, and I know we're not going to go and do MRI, more sophisticated probably. So I think this is a tricky situation. Since Dr. Prof. Dennis also is his favorite topic is the enthesitis, and I know he's published the enthesitis or enthesopathy chapter in one of the major textbooks. And we're talking about also, in addition fibromyalgia, we have other conditions which might mimic enthesitis of spondyloarthropathy. So we're not going to do biopsy, of course. So any way to get around it, especially for people who are not familiar or not with this. Thank you. And that we'll move to the second session. Dr. Prof. Dennis, yes.
Basant, do you want to start?
Yeah, well, you might, if you have a quick comment on this, you can go ahead.
Ultrasound can help in case of obvious cases of enthesitis. So in case of Doppler signal, in case of the synovial complex association, it can help. But you may have an athlete who's already have an esophagus, which is part of his response to his regular mechanical stress. High body mass index also can affect these results and can affect the enthesial sites. So it can help in some situation, but not always.
Yes.
So at that time,
So Dr. Al-Hazmi, quick comment. There is a paper in the Journal of Rheumatology from an Italian multi-center study showing that the mean enthesopathy score is 3 times higher in psoriatics compared to fibromyalgia. But as you say, there's a lot of overlap, and you have to use clinical judgment. The emphasis is often a hidden target in terms of inflammation. It does not play by the rules. And you cannot juxtapose rheumatoid concepts or diabetes concept onto a structure that is largely devoid of an immune system at the insertion in big structures like the Achilles. Completely different concept, and that hasn't got through just yet.
Okay, fair enough. Thank you so much for both of you, Prof. Dennis and Dr. Basant, and you stay with us till the end of this session. At the panel discussion at the end. Now we'll move to the second session and another domain. So, which actually combination of probably some of the domains in the Psoriatic and the SPA group So it's more common, this particular domain, that's the dactylitis, is more common in psoriatic and probably reactive than other diseases in this under the umbrella of SPA group. We are pleased to present Dr. Mohammed Al-Mansour, who is a consultant rheumatologist and head section of rheumatology in King Fahd Medical City in Riyadh. And Dr. Mohammed is going to address this particular domain with regard to pathophysiology and assessment and treatment. Then also Professor Philip, who we have the pleasure to have him here as well. Who is a professor of clinical rheumatology at the University of Leeds, and he's been already introduced, and he's an honorary consultant rheumatologist with Leeds and Bradford Teaching Hospital, and he's a famous figure in the field, a member of ASAS, and also is established and led the Casper study for the classification of psoriatic arthritis, famous TICOBA one, and he has really several hundred papers being published in the field of rheumatology, in particular in SPA. So please, our distinguished speakers, the mic for you, Dr. Mohammed Al-Mansour first, and then we'll followed by Prof. Philip, and we'll get some question at the end, and then we'll close with the panel discussion at the end.
Okay, Assalamu alaikum wa rahmatullahi wa barakatuh. Thanks, Mr. Chairman, Dr. Ahmed, for this nice introduction. Thanks for the organizing committee. And thanks, Novartis, for inviting me to share my talk in this very nice symposium. And I'm glad also to share my talk with Prof. Philip. He's well-known rheumatologist. So let's start our talk about dactylitis as one of the common and distinguished features of seronegative spondyloarthritis as a pathophysiology assessment and treatment. So first of all, I will speak about my case, about the patient, then we'll go to diagnosis, management plan, and then patient follow-up, and finally keynotes. So my patient, MA, 35 years old, Saudi male, patient with 1 year history of skin lesions in his scalp, trunk, as well as lower limbs. His scalp showed erythematous scaly plaques in occipital areas, demarcated scaly erythematous rash over his trunk and lower limbs bilateral, as well as one nail with the onycholysis. Seen initially and started by his dermatologist and local therapy, including betamethasone scalp lotion, as well as tacrolimus. And his BASI score was at that time is 18.3. The patient then was referred to a rheumatologist, and he had some joint pain that involving the small joints of the hand, BIBs and DIBs as well, with significant morning stiffness of around 1 hour. He also has dactylitis involving his left third toe. In clinic, musculoskeletal ultrasound showed that there is a tenosynovitis of grade 2 and peritendinous edema in the left third toe, as well as a tenosynovitis involving multiple joints of the hands with minimum erosion in the 4th and 5th DIB bilateral. And this is the photo for his left foot, showing, as you can see, the diffuse swelling of the left third toe, dactylitis. So his lab initially showing very high inflammatory markers with a CRP of 27 and DSR of 61, and his anti-CCP as well as rheumatoid factor with ANA all were negative. Renal, liver, as well as other labs are negative. We screen him for hepatitis B, C, HIV, as well as quantiferon TB, and all were negative. His DAPSA score initially is 27, which showed moderate disease activity, as well as BAS-DAS of around 4. So usually in our clinic, we are using this screening tools for the activity score, which is DAPSA. Disease activity in psoriatic arthritis score. It's including number of tender joints, as well as swollen joints, together with CRB and patient awareness about his pain, as well as about his joint activity, and then we'll calculate it. If it's from 0 to more than 28 for low disease activity, as well as moderate disease activity till high disease activity. And the other also scoring that we are using in our clinics is BAS-DAS also. It's ranging until more than 5.4 to high activity, and moderate as well from 3 to 5. And our patient was actually occupied in moderate disease activity. So as you know, regarding the Casper criteria for definition of psoriatic arthritis, usually it's making for the classification criteria rather than diagnostic. And in our patient, he is having skin psoriasis as well as nail lesions together with negative rheumatoid factor. So he has almost 4 out of 5 of these criteria. So he is diagnosed to have psoriatic arthritis according to Casper criteria. So we saw him initially, and we started him in secukinumab. We offered for him an steroid injection, but he refused it. So we started him in secukinumab 300 milligram subcutaneous injection weekly for 5 doses as a loading dose, then monthly after that as a maintenance therapy with a diagnosis of psoriatic arthritis and dactylitis. So a 5 principle regarding management plan for treat to target strategies. As you know, the treatment target must be based on a shared decision between your patient as well as a rheumatologist, and treatment to target by measuring the disease activity and adjusting therapy accordingly improve the outcome. And the management of musculoskeletal and non-musculoskeletal manifestation, for example, skin, eye, and GI tracts, comorbidities such as metabolic syndrome, cardiovascular disease, and depression should also be considered and coordinated as needed between the rheumatologist and other specialty. Number 4, goals of treatment are to optimize a long-term health-related quality of life and social participation by control of sign and symptoms, prevention of structural damage, preservation of function, and avoidance of toxicity, and minimizing of comorbidities. And the last point, abrogation of inflammation is important to achieve these goals. So we saw him next time in 16 weeks and within 4 months, and his skin was improved. BASI 90 score improved by around 55%. And his dactylitis also is improved. DAPSA score dropped from 26 to around 10. And BAS-DI score dropped from 4 to 2. And we saw him in 24 weeks, and his symptoms is improved regarding skin, joint, as well as dactylitis. So as you know, the GRAPPA 2021 guidelines on management of psoriatic arthritis and for the dactylitis domain, usually they will start with corticosteroid injection as indicated. Then we can go through the non-steroidal as well as DMARDs, but usually we consider as a biological therapy like interleukin 17 or anti-TNF as a first line therapy in such case. And this is also an update of EULAR 2019 recommendation on PSA according to the disease domain, if it's polyarthritis, oligoenthesitis, as well as the axial, and starting from non-steroidal and then conventional DMARDs, and if not responding, they will go for biological therapy and other targeted synthetic DMARDs like JAK inhibitors and Primalist. So this is the last slide for me regarding the domain and according to the domain presentation in psoriatic arthritis. For example, in our domain like dactylitis, usually they will start with a biological therapy like anti-TNF or interleukin 17, like in case of secukinumab or oxazumab, or interleukin 23 like guselkumab, and also usetukinumab as interleukin 12 and 23. This is my case, and thank you for listening, and interesting to listen for any comments or questions.
Thank you very much. I'd like now to just take over and talk a little bit about the clinical aspects of dactylitis in psoriatic arthritis. I have no disclosures or conflicts. So I'm going to talk about dactylitis definition and attribution, and something about the pathophysiology, slight talking about scoring and how to reference this in your clinic notes. I'm going to give you some tips about spotting dactylitis, and perhaps talk about difficult cases for assessment. So dactylitis is defined as a uniform swelling of a digit, and the swelling is not confined to the joints. So the digit is diffusely swollen, the bits in between the joints as well as the joints. And in it's quite often referred to in England as a sausage digit in the hand, and in the toe, it's like a little sausage, or so-called chipolata. And here are some examples. I mean, the toes are perhaps the most obvious cases here in this top left-hand figure. There are other cases here. In this was a case in our reliability study. I don't know if you can spot the dactylitic finger here, but sometimes it can be quite subtle, particularly if the patient holds his hands like this. But here we have the dactylitic digit. In this case, the dactylitic digit was the index finger, but this was not psoriatic arthritis. I'll come back to that. And I often ask people to spot the dactylitic finger in these hands, and I get various answers, including that finger and this finger and that one sometimes. And in fact, these are my hands. I don't have dactylitis, and I put them up there to show that it can be sometimes hard to spot. It's okay if it's obvious, but sometimes it's a little bit more subtle, and that one was a little bit more subtle as well. And it can be difficult. I mean, there are various things that make it difficult to identify dactylitis. If the psoriasis is extensive, and I'll show you a picture in a minute, then the whole of the finger can look swollen, and particularly in a case like Aleppo, that you might see that. If there's obesity, it's sometimes difficult, particularly in the feet, when all the toes may look dactylitic. And trauma is an important cause. I once had a patient came in, he'd been referred with joint pain, and he had psoriasis at the elbow. And he took his shoes and socks off, and there was a dactylitic toe, the left second toe. And I said, "I know what's wrong with you." And he said, "Why do you say that, doc?" I said, "Because I can see that you've got this sign, dactylitis, in your toe." He said, "Well, actually, I dropped something on that toe yesterday." So trauma can sometimes be a difficult, something to watch out for, and be careful you don't embarrass yourself like I did. Of course, there are other disorders that cause dactylitis. I think I may be coming on to that, but the other disorders include sarcoidosis, which is probably the second most common cause that I see, and TB, of course, of the finger can look dactylitic. And the other common cause is gout, strangely, which we saw in the previous picture here. This is a patient with obviously severe palmoplantar psoriasis who presented with what looked a very podgy thumb and index finger that was initially diagnosed as gout, but really this was just cutaneous involvement. So, as I said, there are other causes such as tuberculosis, sarcoidosis, and gout, but of course an acute infection of the flexor tendon sheath can cause a dactylitis of a digit. So not everything that's dactylitis is psoriatic arthritis or spondyloarthropathy. That's the point I'm trying to make here. In fact, in Rothman's paper, dactylitis is actually more common in sarcoidosis than it is in psoriatic arthritis, but psoriatic arthritis is seen more commonly in the clinic. Rothschild, not Rothman. And in his particular series, 75% of the clinic cases he saw were due to spondyloarthritis, although, as you can see here, sarcoidosis was more common in gout. Dactylitis was more common in sarcoidosis. Here's a case of gout, obviously tophaceous gout, dactylitis of the index finger. So it's not totally confined to psoriatic arthritis. And the epidemiology of dactylitis has been looked at in Daphne Gladman's cohort by John Brockbank, and he found that dactylitis is much more common in the feet than the hands, and more common in multiple digits than single digits. And about half the cases of psoriatic arthritis will have at least one episode of dactylitis during their history. And in the hands, it's more common in the index finger of the dominant hand than the other digits. In the feet, it's more common in the fourth toe rather than the other digits. Now, why would that be so? Well, if you invoke the deep Koebner phenomenon, maybe the index finger gets a little bit more trauma in the hand, and maybe the fourth toe gets a little bit more trauma in the feet, particularly in people who wear shoes all the time. You may not have this problem in Saudi Arabia, so I'd be interested to know which is the most common toe you see involved with dactylitis in people who are obviously not wearing heeled shoes and enclosed toe caps all the time. It's a fairly reliable clinical sign, particularly if it's tender, but we found in our reliability paper that if it was a so-called cold dactylitis, it was very hard to spot for a group of rheumatologists. And this is an example from that reliability study. This patient who probably had dactylitis in the left fifth toe was variously cold in the great toes and the second toe here. This toe, by the way, was not tender. And this is a picture you've just seen, and this is a guy who had it in his right index finger. Interestingly, this guy was a gunslinger. When I say that, he was like, you see these Western movies with people standing in the road and shooting at each other. So he was right-handed, and he used this as his trigger finger. This was the only finger that was involved with dactylitis, which was of interest. So if you've got dactylitis, then that finger is more likely to get radiological damage than other fingers. And I don't know what's happened to the size of these, but that's what it showed in both the hands and feet in Daphne Gladman's series. So I think it's been shown in Daphne's series that acute dactylitis is a marker of severity of disease. So if you do see this, then it's a severity indicator, an indicator for more aggressive treatment. Obviously, it's one of the criteria in the Casper criteria, and it actually may be seen on its own, but rarely. And what's going on in a dactylitic finger? Well, it's variously been described as tenosynovitis by Ignacio Oliveri in 2002, arthritis by Kane et al. In 1999, and enthesitis by Dennis in his Lancet article in 1998. What's going on is probably a mixture of these. We've done MRI studies, and you can see in this image of a dactylitic finger that there's synovitis, there's enthesitis, there's osteitis, there's tenosynovitis, there's even soft tissue edema. all these features occur. It's like a paradigm of psoriatic disease. There's another pictures. And these are the relative frequency of the features that we saw in our cases of dactylitis. Mostly had synovitis and subcutaneous edema. Quite a few had bone edema, tenosynovitis. So I'd like to just pause there. I haven't talked about treatment. I'm happy to, but I just thought we'd have a pause and see if there are any questions in the chat, and whether we can come back to the treatment slides, or I could rapidly go through them. I'm just looking to see if there are any questions at the moment. I'm not sure there are at the present time. Oh, in this, there's a question about starting methotrexate in a dactylitic patient. Okay, well, I'll just finish the presentation then, and then we can come back to this. So in the clinic situation, basically you're just counting those digits with dactylitis, but there are rating systems for it for use in clinical trials. One we developed in Leeds was the Leeds dactylometer. I'm not going to dwell on that because it's not really for routine clinic use, but it does help you pick up those marginal cases that I have already talked about. So I often advocate local steroid injection, but people say, well, where do you put it? Because, you know, of all these tissues involved. Well, you've got a choice really of the joints, the flexor tendon sheaths. You can actually put a soluble steroid in using a Beer's block. But my practice is to inject a joint, probably usually the MCP joint, and I also inject the flexor tendon sheath. So there's 2 injections. And the latest GRAPPA recommendations show which drugs have evidence for efficacy in dactylitis. And this is small, so small, even challenging my eyes. But since I drew up the dactylitis recommendations, I know that this says there's evidence of efficacy for methotrexate, TNF inhibitors, IL-12, 23 and IL-12 inhibitors, IL-17 inhibitors, JAK inhibitors, and a Primalist, PDE4 inhibitors. So quite a spectrum of these drugs have now shown efficacy in dactylitis. So if you see it, you're well on your way to making a diagnosis. It's a strong marker for psoriatic arthritis, and it's a severity marker as well. Generally, it's poorly responsive to drugs like conventional DMARDs, although there has been efficacy shown for methotrexate, and further work is needed. But when people come to me with a new drug, I say you should test it in dactylitis, because all the tissues you see there are going to be impacted, or hopefully impacted, by the drug that you're going to use. So I'll stop there and we'll take any further questions. You're muted.
One of the important domain. Can you hear me?
Yeah, we can hear you.
Okay, I thought I was muted, but I was not actually. So anyhow, thank you for both of you for this nice illustration and an overview of the dactylitic process in the spine, in particular in psoriatic arthritis. And this we come to the end. We don't have any more questions. The last question was, in fact, in here was the treatment for dactylitis. I mean, you already addressed by you, Prof. Philip.
Yeah, there's somebody asking about whether biological or targeted synthetic works best, but who knows? There's no head-to-head studies in dactylitis. In fact, there are no specific studies in dactylitis. It's all secondary evidence. So we don't know. They all have evidence for efficacy.
Yeah, And this recent recommendation, where they have the strong recommendation, conditional recommendation, I mean, methotrexate is back again for dactylitis and enthesitis after like last a few years ago, it was not really conditionally, even now it's there. So at least we have some sort of cheaper way of going and hoping that it might help this non-articular domain of the psoriatic arthritis in particular and SPA in general. So
and you can always inject as well, of course.
Yes. Yeah. Thank you so much. This leads us to the end of the second session. And now with the Dr. Fahda has joined us. So we will go into the panel discussion, which pretty much to address this afternoon session in rheumatology and SPA in particular, psoriatic. It's very exciting subject actually to read, to study with these all domains and stuff like that. So now, if any questions, any comments,
Dr. Azami, we probably shouldn't go to the plenary discussion yet because the dermatology side is still going. They've got to catch up to us.
I see. Okay. Anyhow, I don't see any more question. If any of the participant in these two sessions has any question for anyone in the other group or so.
Yeah, I would like to raise a question actually. Earlier, I wasn't, I didn't have the time because our session was, has to close. If anyone, if you has experience in combination of biologic or at least like, biologics with phosphodiesterase 4 inhibitor for refractory cases. Because we spoke about a treat to target, and in some cases, honestly, it's very difficult to achieve. One of the cases presented by Dr. What's his name? Anyway, I forgot. He presented a case that he had to switch several biologics, and despite all of that, the patient was still active. So I wonder, do we add in such case who ended using IL-17 blocker, do we add the phosphodiesterase inhibitor? Would that add any benefit if the dactylitis or nail is still persistent?
Well, what my practice is if someone's been on methotrexate and then they go on to a biologic, I usually continue with methotrexate in a lower dose. So I always co-prescribe to prevent anti-drug antibody development. It doesn't happen as much as in rheumatoid, but it does still happen. And if in some cases, if they've been on a Primalist, we'll also continue that and the biologic. But there are cost issues in the UK, obviously.
Well, good afternoon, everybody, and welcome today to
going back to that question, combination biologics, I've used it in a few cases. My latest case had inflammatory bowel disease and ankylosing spondylitis, and the only drug that would work for his inflammatory bowel disease was ustekinumab, which didn't do anything for his back, of course. So we managed to put him on etanercept as well as ustekinumab, and he's done okay on that combination. But Dr. Helena answered this question yesterday, and they had a case series of 8 people on combination biologics, and they were mostly on etanercept and ustekinumab combination. And all of them developed side effects sufficient. Oh, there she is now. All of them developed side effects sufficient for them to discontinue. But that is the combination I've used more frequently as well. And of course, there was a biologic developed that had a two-target approach, 17 and TNF. But unfortunately, AbbVie didn't see fit to continue the clinical trials of this drug, and it was discontinued.
Yeah.
You want to add anything to that, Helena?
Yeah, just to qualify on that, it was not all the cases where etanercept plus ustekinumab. We also had monoclonal antibodies, so we had Humira and certolizumab as well.
Okay.
But yeah, you are right that probably the ones on etanercept fared a little bit easier I mean, going back onto the theme, we find that particularly a Premalist is good in combination, and I think the safety profile is truthfully so. I mean, it's basically we see in real life what was reported in clinical trials, and it behaves like methotrexate in a way. So, provided that patients can tolerate it,
Yes,
it is good in. I mean, it is well tolerated in general in combination with biologics. Yeah.
I've just been told that we have a couple of minutes before we move to the unified session. I mean, they're scheduled at 4:30 instead of 4:50.
Okay. Peter.
Peter is here.
Hi, I'm just going to throw in for 5 cents worth that bimekizumab and certolizumab in combination have been tried by UCB. They did RA trials, but the point was there wasn't increased infection when they put those two together. So like Helena said, she tried a couple with 17 plus TNF in those really difficult cases, but you just have to be careful, and it's an expensive combination.
Yeah, I think the combination that I've used, the etanercept and ustekinumab, they're both relatively safe drugs, and we haven't had any major problems with infection with those two.
I mean, you have to choose your patients, obviously. The older the patient, the more comorbid, the more fragile in general, particularly on polypharmacy, the less likely they are. And in fact, those were the ones that came off the treatment first in our series. The younger ones, fitter, and with shorter disease duration, were the ones that lasted longer. But again, 2 years was definitely our top margin. I don't think we can advocate this as the way to go, at least until we develop, newer, perhaps safer agents.
Okay.
And with the AbbVie drug, the problem was that the combo wasn't better than adalimumab by itself. So the bean counters decided not to develop it any further.
Yes, yeah.
I actually thought it was slightly superior. I think they were a bit hard on the results there.
Well, it wasn't enough to convince them to go ahead.
No,
and they had UPA in the back pocket, so they decided.
Exactly. I think UPA was the big decision maker there.
You've got some questions in the chat. I don't know whether you've been looking at them.
Yeah, a couple of questions there. One of the audience is asking whether we need to maintain a methotrexate while adding a second line biologic or cell target therapy, and namely she or he talks about JAK or secukinumab. What do you do with methotrexate?
Well, I just said I always try and continue the methotrexate when I switch to a biologic. I will reduce the dose. My ideal methotrexate code prescription dose is 15 milligrams a week.
Yeah, I think it depends on the scenario. If patients are doing well, and particularly if they don't have side effects, I mean, obviously they're not doing well if we need to add on the second drug, but if they're not having side effects with the methotrexate, yes, I'm inclined to add on the biologic and then withdraw the methotrexate. If people have been struggling or they are on a very low methotrexate dose, I'll probably just stop it, start the biologic in a single therapy, and then consider re-adding either methotrexate or another conventional DMARD if needed. So it depends on the scenario, and also depends on whether it's the skin or the joints the main problem. So I think there's a bit of juggling space there. But if you can't just give single therapy, there may not be that much of a need for combo.
Case-to-case basis, basically, and if the patient is unique, I think we're being told that we have to move to the other room because people are waiting for us there.
Okay.
So,
how do we do that?
I don't know.
They will do it. They will do it.
We're